Welcome everybody. We're letting the last few people join in for our upcoming webinar here. So bear with us as we allow the last few people to enter for sound check purposes. Dr. Mullen, can you hear me? Can you say
I can hear you.
Very good. Alex, are you good?
Good.
Alrighty. So I'm going to get our stop thing started here so I know to keep us on time. Got the stopwatch. Very good. So looks like we've got the last few people. Welcome everyone. We're going to be talking today's webinar about telehealth, the next generation, women found, women led for women's health. This is another of the Interview with Impact Thought Leadership webinar series. So we'll be starting just a few seconds. Looks like the last ones are coming in. Give us about another 30 seconds. All right, we're going to launch it officially now. So welcome again, everyone. We appreciate you making time out of your busy day to be a part of what we believe is going to be a very insightful, educational, encouraging content piece, ideally suited for our investor relationships within the family office, the alternative and the impact investing communities. We've decided to focus today on telehealth, the next generation, women founded, women led for women's health. And I'm pleased to have our thought leaders today. I'm going to introduce them briefly. Dr. Tiffany Mullen, co-founder of Vytal Health. Say hello, Tiffany.
Hello, everyone.
All right. I've got Dr. Alex as well. Alex, you there?
Yep, I'm here. Hi.
Very good. Very good. And my name's Danny Hughes. I'll be doing my best to moderate and navigate this group through this content that we want to make sure that is hyper engaging, educational, give people some insights as to what we're seeing in some markets that I think are going to be exciting for us to explore together. And so we're going to dive in right into the content. The agenda that we've had laid out today is we're going to start with the introductions, which we're doing today, right now. We're going to move into the topic that I'd like for Dr. Tiffany Mullen to weigh in heavily on is challenges facing female health consumers in today's market. There's a lot of great insights, trends that I believe will be warranted, and there'll be a lot of people who know and appreciate what's going on in that sector, nodding heads and agreeing with what some of these challenges are facing. Then we're going to transition into telehealth, the past, the present, and the future. We'll have Dr. Alex weigh in on some of his insights of being an active part of this, seeing the trends develop, as well as being able to weigh in on what the future holds for us. We then allow both parties to share about the architecting of what is that ideal telehealth solution look like for women, since this is a content piece, an educational webinar dedicated to that market segment. We'll allow them to touch a little bit, wrapping up about what is Vytal Health. Then we'll bring it home with some Q&A that we'll have people ask during the time. And then we'll follow up with some next action items. So if that sounds like a good game plan, let's start off here. Dr. Tiffany, you rather call me Dr. Tiffany, Dr. Mullen? What would you like me to call
Oh my gosh.
you? You know, either one is fine?
Either one, or just Tiffany is fine as well.
Tiffany is great.
Sure.
So, you know, we've got an aggressive agenda. We started to talk off about what are these challenges. So we've included a couple industry comments, and I'd like for you to have a chance to weigh in your thoughts on this as we transition into things specifically. So what are you seeing in the marketplace?
Yeah, I mean, so I've been a practicing physician for 20 years. And when I read this article from Dame, what was so striking to me is the word that's right sort of smack in the middle of the slide, which is the word dismissed. It is a word that I think I hear regularly from patients, women patients, who are going to the doctor and unfortunately feeling as though their needs are not being met. And it's become such a common experience that it is a theme in my practice, and it's been a theme in my practice. It's a theme in my practice at Vytal Health, for women to feel dismissed by doctors and feel as though their needs are not getting met. So unfortunately, I don't see this as something that is a passing phase. I have seen it for such a long time that I believe that this is sort of germane in the DNA of our healthcare system as it is today. And we'll talk a little bit about that in a minute, but this is a significant problem for women.
Yes, I've seen the same thing. And here's another one that I thought was interesting. That is this sort of aligned with what the last one was saying as well?
Yeah, very much so. And I think so. This is about pain, this particular article, and about how women don't receive enough in-depth care around management of their pain. And I think a lot of us have probably heard the headlines also about how often, for example, cardiovascular disease or even myocardial infarctions, heart attacks are missed in women because they present differently and they require a different lens in order to be able to realize what's happening with women. And later, we'll talk a little bit about menopause as sort of being front and center in that, how many women are seeking help for problems and are not getting them because doctors are just not able to recognize or take the time to treat them well.
Is it primarily your experience? Is it because of that time, or is it also in parallel a limited or lack of knowledge about all of the different variances of challenges and pains that women may be feeling? Is it the time, or is it the knowledge, or both?
I think it's both very much. I think the time is necessary to understand a woman in the context of her symptoms, in the context of her life. But also, if you think about the research that's been done over the last several decades, the research has been done primarily on men. And so when we look at the outcomes for women around cardiovascular disease, as an example, or even management of menopause, these are studies that were either poorly designed or did not include women. And so there is a lack of knowledge. There's a lack of in-depth research in women's health that sets doctors up for just not having a good understanding of how to proceed.
Interesting.
Yeah.
Now, to me, that those are sort of the landscape of what happens. Are there specific buckets or pillars of challenges that you're seeing facing the female healthcare?
Yeah, so it's the four that you see here, and I think that they all kind of blend together in the way that they affect a woman patient. So the quality piece, definitely impacted by the trust and relationship, and that is coming out of basically this idea of the transactional office visit and not having enough time to build trust and build a relationship with a female patient. And she wants that. I mean, that's definitely a part of the way that she conducts herself in a medical setting and the way that she wants to form a relationship with someone. It sort of harkens back to that Dame article where women are going to the internet and going to other resources because they don't have a trusted relationship with a physician. And then that blends into the lack of the healthcare system's ability to understand the challenges of women in their work life and home life. And that is particularly evident right now with COVID, and women having to really think about how they're going to manage their professional lives and personal lives in a new way and for the unforeseeable future. And then women's health being a very specific area where there are lots of clinical conditions where lots of women are affected, and the solutions that are being brought to the table because of the fact that this is a transactional paradigm, they're just not effective. And so women are not getting the help that they need.
I think, each of these have a lot of weight and impact. I think it'd be smart if we dig into them a little bit deeper. So if we said, let's talk a little bit more, exhaust some of this quality and approach. So what is it that they're experiencing today, and where is that limiting?
Yeah, so I mentioned earlier that this idea of the rapid transactional visit as being the way that healthcare is practiced now, it's a volume-based practice where doctors are seeing patients 4 or 5 an hour, and those visits therefore are lasting 10 or 15 minutes. And during that time, really the only tool that you can deploy in that setting is pills. And so there's an idea of sort of treating the symptoms, doing this pill for ill approach where women are given prescriptions for the symptoms that they're experiencing instead of really diving in and getting some in-depth knowledge and understanding what's going on with that woman and trying to solve it at the root. And then that just ultimately breeds a lack of personalization, because every single person that's coming in with migraine headaches, for example, is being treated exactly the same way. Women are in charge of a lot of the healthcare spend and a lot of the healthcare decisions. Up to 80% of healthcare decisions are made by women for herself and her family. And she's spending a lot of time and money to try to solve problems for herself and her family, and not getting the help that she needs. And then finally, when she's walking out of that office visit and she's getting in her car to drive away from the clinic, she doesn't know what to do next. And she's really left to try to figure it out by herself and connect the dots on her own. And that can be very overwhelming for people.
Interesting things that you point out here, because it brings to mind a couple things. One is, in your estimation, is this resulting in I continue to go and then I'll walk away with the wrong or incomplete diagnosis to try to solve?
Yes.
Or does it make me want to resist from even bothering with the process and say, you know, I don't go, I don't take my family because these have been my repeated experience. I don't want to do that. Therefore, without a clear alternative, I still do that. Is that?
Yes.
Is it both of those or more one or the other?
I think it's both, but I'd particularly like to focus on the second one, because I hear so often from my patients that they've essentially let the relationship with their primary physician go because they just derived zero value from it. So once they got to the point where they had been treated like this for so many visits in a row, where they were given a stack of prescriptions, which they ultimately do not fill because it's not in alignment with what they want, and they don't feel satisfied with the answers that they're getting, but they'll walk away and they'll say, like, I don't have any use for my doctor because they're not giving me what I want. And therefore, I'm just not going to engage in the healthcare system. And you can imagine that that has a really significant detrimental effect, because sometimes that means women aren't getting the care that they need in the timeliness that they need to get that care. Yeah.
Exactly. Let's go on to number 2 here. Now that sort of leads into that trust and relationship thing.
Right. Yeah. So again, it's having this limited access to the physician, where so many physicians who are practicing in this very high volume world don't have the time it takes to sit down and listen to patients. They don't have the time to actually move patients into their clinic because they're double and triple booked and they're tearing through their day. And therefore, the interface that the patient has is oftentimes with somebody who's non-clinical at the front line, who's gatekeeping for that physician and not allowing that patient to connect with their doctor in any meaningful way, and therefore nothing gets solved. Physicians are under just incredible productivity demands. I've been in that situation. I practiced under productivity for much of my career, and it's an incredibly hard thing to meet the demands of a productivity model and your patients at the same time. It's almost like they are mutually exclusive. It's not possible, which then means that physicians burn out, their empathy turns off, they become sort of technicians on the front line. And then the woman is left with not having that trusted advisor, no relationship, nowhere to turn. She's not sure where to go with her symptoms, what to do about her problem. So it's a real dismantling of the whole process.
Sure. And is it horse carriage, chicken egg? Is the physicians, in your experience, are they sort of moved into this sort of dynamics of the pressures and the demands of this volume? It takes away from where they would really like to focus, or more of them wanting and have that appetite or desire to have more meaningful, deeper connection. So I can see it from the consumer, the woman's health consumer side, saying, gosh, I wish it was available. Do doctors feel the same way?
They very much do feel the same way. I don't know too many doctors, honestly, who didn't go into medical school and go into healthcare because they didn't want to take care of patients. They didn't want to care about patients. We all go into it with such altruism that it is really, unfortunately, the system designed where it is you get paid for moving as many bodies as you can through the system, through the office, and then doing things to patients, not doing things for patients, that ultimately causes that physician to experience burnout. Burnout has escalated over the last year. I think the latest statistic is 68% of physicians have felt symptoms of burnout. And suicide rates are highest amongst physicians of all professionals. It is an incredibly sad, and it's a sad thing as a physician to see what's happening to physicians and their lack of ability to care for the patients in the way that they want to. And I think that this is especially true for women doctors who ultimately have that empathy hardwired, that caretaking hardwired into them. Not to say that men don't, but women particularly, I think, are impacted by this.
Sure, sure. So we've covered 2, so I see our layers lining up here. So let's go to number 3, work and home. What are you seeing here?
So this is a really interesting time to be talking about this, because I mentioned earlier, COVID has really created this unusual set of circumstances for women, for men too, in the home, who are, so now all parents or people, even without children, are working in home, and their care needs are different. They're now, trying to do their job and try to meet all of the demands of their work, plus take care of their children alongside them. And so it's this really unique circumstance. Additionally, women are really moving up in their careers. And so there's a lot of mobility for women professionally. And consequently, they're moving up in the professional world. And oftentimes they're taking jobs in new geographies. And every time that happens, or a spouse takes a new job in a new geography, they lose that trusted connection with their physician if they have one. Now they're in a new town, a new state, and they just have no idea who to trust, and they have to start all over again. And then there's just expectations of female consumers. Females really want to have that connection with their doctor. They really want to have the time to unpack problems and solve them and understand their bodies and understand how things are working. And, they're smart, and they want to have a collaborative relationship with their doctor. And that's just breaking down as they're having to move around and deal with all the things that they have to deal with in their home.
Well, here's some interesting thoughts that I just reflected on here that you shared. What I wonder how many, I know I've moved a lot of times, and the process of thinking, my gosh, if I take this opportunity or if I move this location, look at all the things I have to deal with. I have to, pack, move, kids, families, relationships. Oh, and I've got all this history with these doctors over here that may have some of these issues, or helping me and my family member deal with it. I wonder how many of them reject the opportunity just because it just seems to be too much to deal with that they got to. I really want to start over. That's one thought.
Yeah.
The other one is, granted, work from home and work balance and the demands and the COVID has pressured on us. I think this will be a nice lead in for what Alex will cover the next section about this past, present, future of telehealth, is that we've become comfortable with things like Zoom and with exchanging and building relationships via this digital medium. So I think there's challenges and opportunities
Agreed.
In here that's worth exploring at a future time.
That's absolutely true.
All right, last one. Let's talk about these unique conditions.
Right. So this is a short list. Obviously, this is not a comprehensive list of health conditions that are either unique to women or more common in women. But I think what's important to note here is that the numbers of millions of women that are in parentheses after each condition are not the number of women who have the condition, but the number of women who work and have the condition. And I think that is notable for the fact that these are really significant problems that women are dealing with that are often ineffectively treated, that have high cost associated with them, not just out-of-pocket costs to the woman herself, but lost productivity, lost professional opportunities, to your point in the last slide, lost, productivity from the employer side, high cost in terms of employer spend. So these are really very troubling problems that women are dealing with. And they're problems that aren't talked about. I mean, we tend to focus when we're in an employment situation, we're focusing on, the claims data around diabetes and cardiovascular disease and orthopedics. These are all those sort of unmentionables that nobody wants to talk about because they're taboo or maybe embarrassing. But yet women are dealing with these things that are costing them days and days of work. There's some statistics in slides later on about some of these conditions, but these are significant issues that need a better course of care and a more focused approach that solves the root instead of covers the symptoms.
Yeah, agreed. And with that, as you talked about, we may not want to have to hit all of them, but let's dig into some of these that you feel are most relevant. So I think the first one we talked about, I like this slide. This is very good. Talk about this one.
Yeah. So all of this is to say, these 4 pillars or these 4 quadrants are really about dissatisfaction. And I think it's always really shocking to people when they hear that this study that was done in conjunction with GE Healthcare and Profit showed an 80% dissatisfaction. That's just an astounding number of women that are dissatisfied with their healthcare experience. I mean, there's really no other sector in the market where we would tolerate 80% dissatisfaction and sit on our hands. There's 75% of frequent healthcare users. So the people who are actually touching the healthcare system, 75% of them are dissatisfied. And you can imagine that that's primarily women, a small group of men. And then people who don't even really touch the healthcare system much at all, other healthcare consumers, almost half of them are dissatisfied. So there's a huge opportunity, I think, to make this right for women, for people, but particularly for women, since they are the drivers of the healthcare decisions. They are impacted by this. They have clinical conditions that aren't being addressed well. You know, this is a real like aha moment. I think most of us, when we look at this, we want to do better.
Yeah, very good.
Yeah.
So coming back to some of those, drilling into more deeply, again, we may not want to hit all of them, but let's talk about some of these that you feel like have the biggest impact on some of these health-related issues.
Yeah, I think some of these are worth digging in a little bit deeper on, because when we said 27 million working women were struggling with menopause, what we talk about is the fact that 80% of women in that 45 to 55 average kind of mean range of menopause age are symptomatic, and they're going to their doctors and they're asking for help, and only 5 to 6% of them are offered any treatment at all. Most physicians, having been scarred by some of the now 15-year-old data that was a very poorly done study, the Women's Health Initiative study, they have just dropped the ball tremendously in helping women get relief. And these are women who are right at the peak of their career. They're managing teams. They're moving up the career ladder. They have direct reports. They are working themselves to the bone to try to ultimately get where they want to get in their career. And now they're being dealt this hand. I don't know that there are too many men that would put up with 5 to 6% treatment offered and just walk around symptomatic and have it kill your day, because you basically can't focus, you can't sleep, your mood is impacted, you're having hot flashes in the middle of presentations. This is a big deal. This is a big deal for a lot of women.
It is. And it's easy to start seeing connective tissue, because that 5 to 6% offered treatment, that's a function of the time, right? We go back to that. How much time does somebody actually get to spend with them?
Right.
And B, the knowledge gap of any general practitioner to sensitivities about these issues, right? So
and the dismissal that we talked about. Right.
Yeah.
The dismissal, which is, this is where you are in your life. Get over it.
Yeah.
That's literally what women are told, which is, I would say abusive, frankly.
Yeah. Well, I like your point that how many professional men would be accepting if 80% are symptomatic in their days about anything, and there was only 6% with a treatment,
right,
we're still able to go off and try to be expected to have high achievements and productivity. That wouldn't be tolerated at all.
Absolutely.
So, is this one worth digging into, or do you want to?
I mean, I think we can just briefly talk about the fact that we alluded to earlier, when people change jobs and they're making decisions about what to do in terms of, do I want to take this new position or not? I think people need to understand that a lot of millennials particularly are making decisions about a job change based on fertility coverage. So right in the middle of this slide, you see that 68% of employees will change jobs for fertility coverage. 70% of those are millennials, and 90% of those struggling with infertility will change jobs for the fertility coverage. So it is a big deal. And so I think when we talk about benefits driving attracting talent and attracting employees that are valuable and keeping them, these are important things to keep in mind.
Correct. And I think this sort of weighs in what we'll talk about a little bit, in that, what does the ideal solution look like? We'll touch on that, I think, a little bit later.
Yep.
How about this one?
Yeah. So again, this is one of those unmentionable problems that impacts both men and women, but a lot of women, nearly 15 million working women. And what struck me about this is the amount of absenteeism that is involved in irritable bowel syndrome. 24% absenteeism and 86% presenteeism, meaning these people are showing up for work. If they show up, they're showing up for work and they're really not able to participate in the responsibilities that they have in the workplace because they're so symptomatic. And it is one of those kind of problems that's embarrassing enough that people will just stay home if they're
no one's
feeling
gonna really
particularly
wanna bring that
bad.
up.
Yeah,
Right,
exactly.
right. Yes, this one here.
And then migraines, I think, there's a lot of people with migraines, both men and women, but 28 million working women. And I think it's just really interesting to look at the lost work time with migraines. 11% of people stay home, 5% went to work late in this particular study, and that's on average about 2 hours late, and 12% left work early. And again, that was about 2 hours early. The impact financially with migraines is huge. This is an old enough study that some of the most expensive drugs that have been introduced into the migraine space aren't even taken into account in these costs. But that number has just shot up because new pharmaceuticals that have come onto the market are just tremendously expensive and out of the reach of a lot of women.
Oh, good. So we'll let you take a break, Tiffany.
Okay, sounds good.
That was impressive. Alex, you get to step up.
All right.
I'd love for you to share with the audience now, both, the industry, the trends, what's taking place. We'll talk a little bit about some of the underlying technology, which you have such a strong grasp of. But let's talk about in its origin. Telemedicine was primarily a solution used for what?
Yeah, so initially when telemedicine first came about in the early 2000s, and I've been doing telemedicine work for 13 years now and been quite exposed to this area and very involved in it, especially in the pharmacy world. But it initially started out with ICU monitoring, and in pharmacy we started doing telepharmacy and remote dispensing. Then came primary care and urgent care models to help with the transactional visits and allow physicians to spend more time in primary care, helping patients and taking off some of the urgent care visits virtually, and building platforms really to help facilitate the urgent care visits. And then later on, specifically in this past decade, physical therapy and as well as some teletherapy, we'll talk about a little later, came in the market as well. And that's kind of within the health system, how it was being utilized. On the outside of the health system, facing the consumer. So the consumers had access to urgent care. Consumers had access to telepharmacy and remote dispensing models, vending machines with in small towns where there is no pharmacist on staff where they can get prescription medications. And again, over the last 5 years or so, more psychotherapy options are available to consumers, as well as some condition-specific care. And again, we'll touch on that a little later. But there's been just such an evolution of telemedicine as people got more comfortable with it. We figured out the privacy concerns that were initially present, figured out the technology buy-in and barriers, and COVID totally just propelled that into the future significantly, because people were just forced to use telemedicine and forced to try it, actually. Not forced to use it, but forced to try it. And as we'll see later, a lot of them are very happy with it.
Yeah. So the thing I take away from this slide is that in inception, in its core concept in the beginning, there were two drivers. The healthcare system saying, okay, I've got somebody who is in ICU, and in the facility, I want to be able to have monitoring of that patient in the hospital. Is that right?
Yes. We had cost management and access. So you only have so many specialists that are available.
I got it.
And you can't afford to have them all at all places. So some small remote clinics, small remote hospitals couldn't afford to have certain specialists on staff unless they were telemonitored in or televideoed in.
Got it. And then on the consumer side, there was a drive to support consumers' need for medication engagement, meaning I got the doctor, I'm outside of the healthcare system, but to check in on medication, there's psychotherapy and condition-specific care. So those are the two instruments that were early drivers of telemedicine application, right?
Yeah, it was simple things that we could do with telemedicine that we thought were the only things we could do with telemedicine in the consumer side, which is like an urgent care visit, run your nose. education on medications and such. And then it continued to evolve as we got better and better and more comfortable with it.
Got it. So that's a good point, more comfortable with it. So let's talk about what do both the patient and the doctor think about telemedicine, both, you know, in this journey of what has taken place moving up to present.
You know, it's these are interesting stats here, but I just like to tell a quick story. My first experience with telehealth was working for a large health system where we had some small town pharmacies that just financially were not feasible to continue to operate anymore. Mm-hmm. And we introduced telepharmacy, where we had a pharmacist do video consultations with patients. And this was in small rural areas where we just thought we were going to have so much pushback. And we did initially when patients thought that this was going to be something out of the future, something they weren't going to like. But what we learned really, really early on is that it allowed for more attention. Because as you can imagine, a busy pharmacist at a Walgreens or a CVS doing a million things at once isn't able to dedicate enough attention to the patient. Whereas when you do a video visit, it's one-on-one, it's full attention. And both our pharmacists and their patients realized that this was better quality of a consultation and care. So this is just a pharmacy example. But then when we look at it as a whole in medicine and in healthcare, it's better access. It's allowing you to access people today, tomorrow, and not having to wait for months to get in. It's more efficient because you bypass the waiting room. You bypass that doctor who's running 15, 20, 30, 45 minutes late that we're all experienced. And we don't have to staff, we can cut staffing costs because now we don't have to staff the waiting room. We don't have to have somebody room you and have all the equipment that we have in exam rooms, as we can push more people over through the video channels. And on the patient side, patients really tend to like it as well because it's more convenient for them. They can do it on their schedule. They can do it without leaving home, without having to get a babysitter for their 2-3 kids or bring them with, which is even worse. They realize the quality is just about the same. As we know now with so many video conferences, interactions are basically just the same. You can form the same bond, you can have as much empathy, and you can read each other almost as good as in person.
Yeah. Here's what I like though. It's because, you know, just because it might have started with rural application of pharmacy, all of a sudden says, wait a second, maybe I could do it with this type of visit. And then maybe I get to stack on this type of relationship, and maybe I can do it with my primary care and my urgent care. And so I think that early successes in certain applications have sort of lend itself to growth of adoption, acceptance, and even preference from both the consumer side and the physician side.
Yeah, absolutely. And I think it's also, as we get more comfortable with it, we then realize, okay, if we were able to do that, we can do this next, and we can even do this next, where initially it may have been too out there to think that we could do a primary care visit by video. Now we realize we absolutely can.
Correct. Correct. So let's move into here. So you mentioned 2000 and some of the early implementations of, let's walk through this timeline of things that we're looking for. Because I see we've got that urgent care, physician to physician, pharmacist solution back in 2000. And here are some of the names that have been organizations that have been implemented to support the telehealth, and then moving into some of the present day. Walk us through what I'm looking at here.
Yeah, and this is not an all-inclusive list, of course, but it all started initially with building platforms that could handle telemedicine, that could handle urgent care visits. And really a lot of, with Teledoc, Amwell, and MD Live, a lot of the efforts went into building the platform to sustain scalable urgent care visits and making urgent care more accessible.
And did that include all that HIPAA stuff, regulations?
Yes.
You got to be able to electronic files and all that. So that was
So it was
foundation laying. Okay.
Exactly. And it was where the thought was that it was the starting building block basically for everything. Inside the health system, when we started doing physician-to-physician solutions, it was basically just making sure you have secure video access to each other and being able to consult with a specialist on demand. But it wasn't a separate platform initially. And then as we moved on and we got comfortable with some urgent care, some physician-to-physician solutions. Then we started doing telepharmacy. We started introducing some of the other solutions you see here, such as therapy solutions. And we're seeing more and more with teletherapy because of the huge shortage and lack of access to therapists. Psychotherapists, we even see physical therapy that's being done virtually, whether it's inside of a health system or even at home with some equipment and technology.
Mm-hmm. Is that teletherapy solution bucket as you move from 2010 to 2020, is that where you have a pool of people who might need mental health or depression related counseling, like transactional, I've got the problem now, connect to a bucket of people who are therapists who are able and willing to connect and then maybe have that one-to-one? Is that sort of that teletherapy?
Yeah, and that's actually, it's interesting you bring this up because this is actually has been kind of the progression of this as well. It all started with the transactional. I have a problem that I need solved right now. I don't really need a relationship with the person I'm talking to. I just need a solution. So that's kind of your urgent care visit. And initially with therapy, it was kind of like that as well, where it's you plug in and you get a therapist out of a pool of whoever's available in a queue. And now we're moving towards, well, can we actually have a relationship? Can I have my therapist that I'm seeing for my anxiety or for my issues that I'm dealing with?
Got it.
And we'll see that there's quite a bit of that coming.
Yeah. So now we see now a bigger bucket of activities because I think the foundation's been laid from an infrastructure. The acceptance has grown via the urgent to urgent care, via the teletherapy. So now we're starting to see more of an appetite. This is what we'll call up to now and next generation. What's your observations here you want to share?
Yeah, so I think it's also we're getting more creative. So we're starting to think creatively about what other problems or things can we solve with telemedicine and telehealth. We'll talk about these companies here and we'll lay them out slightly differently so it's a little easier on the eyes. But really, it's just we're seeing a lot more variety coming into the marketplace and focus on solving specific problems, specific health conditions, helping specific people. So maybe it's men's health, women's health. And then what we saw with COVID here, and really this is, we touched on this earlier, but this is what kind of pushed telemedicine into being a common, household name. And so many people, even my 96-year-old grandmother has done a telemedicine visit now. So it's the adoption is it's normal now.
What I think is exciting here is that you touched on it in your last comment is that it's starting to move into the deeper relationship side, right? It's saying, okay, we can not only target a demographic, a problem, but facilitate relationships that become trusted and solve some of those problems that women health consumers. Is that what you're seeing?
Yeah, and specifically over the last few years, we're seeing more and more of the relationship building.
Yeah. I like that we've got Vytal Health right up here on the upper right. We'll dig into a little bit more about where you guys see yourself in Vytal Health in the ecosystem. But I like this slide. So that's an encouraging next generation transition.
Yeah, and then
this is a good one here. Okay, so that's almost touched on what we were just mentioning here.
Yeah, exactly.
Transactional to ongoing relationship, specific health problem to what's that say over on the far right?
So this is women's healthcare and all stages of life. Yeah, sure. So, we are in the women's health space. So we're looking at other companies that are providing women's health solutions. And what we've noticed is early on when companies and people first started getting more creative with telemedicine, things were really coming out that were specific to specific health problems. So Maven and Kindbody, they're very focused on fertility solutions. Then we have Lemonade, Hers, and a few other companies that are more general, but they're very transactional. So it's really about that almost like an urgent care visit, but it's like, I need a prescription, I need birth control, I need an erectile dysfunction medication, and here's how I get access to it. And what we're seeing happening over the last few years is companies coming out with solutions that are more ongoing. They're more relationship oriented because that's what consumers want. They want that relationship with the doctor, and they want a different approach. So SteadyMD and Parsley Health are some of the probably closest competitors to what we do in the space of holistic medicine and whole person health. And they're focused on that relationship building just like we are. On the right side, we're seeing companies coming out and starting to support women throughout their basically all stages of life, not just focusing on menopause or not just focusing on fertility and reproductive years, but really supporting a woman as she grows and ages.
Excellent. Excellent. Nice. Wow. Okay. So now we've had, Tiffany, you've had a chance to weigh in. Alex, you've had a chance to weigh in from a technology standpoint. Let's, with those two things in mind that we've learned and we've espoused on, let's talk about, in a perfect world, what would an ideal solution for the woman health consumer look like?
Right. So when we look at that, if you'll recall that earlier slide with 80% of women being dissatisfied with their care, when you dig into the why behind the dissatisfaction, you start to tease apart some of the reasons why she's dissatisfied and what she's looking for. So the GE Health study really teased that apart. And honestly, so have we as a company, having talked to patients for so many years about what is missing for them and what they want. So what we hear from both the study group as well as our own patients is a membership model that's a simple, straightforward way to pay for care. Whole person care is incredibly important to women. And what do we mean by that? We'll dig into it in a little bit, but really just lifestyle focused, personalized, holistic, having choices in your care so that it's not just pharmaceutical or procedure, but rather what can I do in my own life to get better? That long-standing relationship that Alex really emphasized in the last slide that women want over time and over geographies, and then being able to access their doctor when and where they need the care, and be able to dial up and dial down the amount of time that they want to spend with their doctor. And then that sort of experience where women, I mentioned earlier, where they're leaving the clinic and falling into this place where they're now having to put the care together, connect the dots. That concierge experience of being able to navigate the healthcare system, because we all know that these telemedicine solutions are awesome, but that care does not begin and end with a telemedicine visit. We still have extension into the healthcare system. We still have extension into other interactions with healthcare solutions, and we need to be able to help women navigate that experience.
You know, I'm looking at these points. I would imagine it would be even applicable to include, when you look at the architect, the ideal solution, something you pointed on a couple times, Tiffany, is the women are not only about their own, but they also have their family members and the relationships that they're looking for to support family members as well. So I would imagine not only whole person, but whole family.
Exactly.
The ability to support and have a primary care for yourself or your children, spouses, family members. Also have that point person who can say, here's what all this means, and here's what my recommendation is as a course of action. I think that'd be valuable.
Oh yeah, just that trusted relationship again. Who do you turn to when you need help? When you need help for yourself, your spouse, your partner, your children, your parents. A lot of these women are in the sandwich generation where they're taking care of both their younger generations and their older generations, and they need help with making decisions. And having somebody to trust is so incredibly important.
Now, you mentioned it. Let's see, what we talked about whole person care.
Yeah.
I think it's worthy diving in. What does whole person care mean?
Well, we talk about whole person care because what has happened along the trajectory of what we'll call holistic medicine is it's changed names several times. It was complementary and alternative medicine, integrative medicine, functional medicine, naturopathic medicine, anti-aging medicine. There's all of these approaches, and they are just approaches to solving health problems at the root cause and with the most evidence-based natural approaches whenever possible, but keeping in mind that each woman has her own value system and that she deserves to weigh in and be collaborated with on the solution of her choice. So it's looking at nutrition and family relationships and exercise, genomics, doing in-depth testing, really understanding mind and body and spirit and how they all link together, that I think really describes whole person care. And I have not met a woman to this day really, I haven't met a person, but let's just say women who have not said to me, that's what I want. That's how I want to be treated. That's what I want in my healthcare as a patient. And it's always what I have demanded in my own healthcare. And I think it's what most women want to have.
You know, I've had a chance to socialize this to several people, some of the high net worth community, family office members. And, you know, that point you made earlier about how is it possible that with an 80%, it's almost like the only industry in which you can have an 80% dissatisfaction rate, be paying lots of money, either
Right.
through healthcare or out of healthcare.
Yeah.
And that's the one that you tolerate. It's like, well, until someone else gives me a better option,
Right.
I really don't have much choice. And
It's
so
astonishing.
it is astonishing. And so
Yeah.
the ability to be able to have people have insight into a possibility of what a whole person care might look like and imagine it and being able to provide some of that solution. It says that is, you know, again, paying for what you deserve and what you want. I would argue that sometimes people's biggest concerns about the rising cost of healthcare, which is excessive.
Right.
But if it was, you know, King Midas gold quality service, you might be sitting there saying, well, you know, you're getting what you're paying for. But
yeah, no, we're doing a terrible job and we're paying through the nose. Yeah.
You don't get that experience. You're like,
totally.
what am I doing here?
I know. And patients are smart. That's exactly what they're thinking. They're saying, gosh, I'm looking at my healthcare spend going up every single year. My employer is passing on more and more of the cost to me. And sometimes they have to.
And I go less. And I go
and
less.
Yes, and I have less
and I
access.
Don't want to go. Yeah.
And I don't want to go. And it's terrible. It's terrible. Like, what am I paying for? If I had the option, I would ditch this whole thing and start something differently. And if we actually listen to patients, they'll tell us what they want. And they'll tell us a really good way to get it done. So that's what we do. We actually listen to the patients.
Yeah. I think that's a good lead into this right here. We won't belabor this too much because this is about, you know, trends and education, but let's just give people a touch on what is Vytal Health and what you're aiming for.
So, is this an Alex slide? Sorry, go ahead, Alex.
Alex, go ahead.
Just got excited.
Well, you can, why don't you take it then?
Well, I mean, so what we've really done is we've designed this telemedicine solution that's virtual healthcare in a whole person or holistic way for women who are busy and working or busy and are trying to get things done. We wanted to make it as simple, accessible, and whole person oriented as possible. So that's exactly what we designed based on the feedback from our patients.
Sure. And, you know, again, I'll make this commentary and let Alec weigh in a little bit on it. I know you guys are based in the Midwest in Milwaukee. Mm-hmm. One of the things, and we led this with the beginning slide, that there's such an appetite and a growing appetite from the alternative and the impact investor community to find impactful organization business ventures that are women-found, women-led, and the fact that it's for women's health is just the icing on the cake.
Yeah.
Being able to put all of these things. Alex, talk about points 3 through 5 here.
So the holistic telemedicine plus wraparound services and products. So what that really means is we have a few core beliefs that are really near and dear to our heart. One is relationship. We believe that there should be a relationship in healthcare between your doctor, your team that's taking care of you, and you. You should never feel alone. You should never feel what we call a medical black hole. It's when you leave the doctor's office and you disappear. You disappear into your own little universe. You feel completely unsupported, and the doctor has no idea what's happening with you. So relationships are extremely important to us. The other thing that's extremely core to what we do is empathy. We've been patients. Our doctors have been patients. There's a reason why people decide to go this route with their medical practice, and we really feel strongly about that being one of the core drivers to what we deliver to patients. So that we designed our system and our services to support all of that. So patients never feel alone. Doctors always feel supported and have access to the latest information on their patients. We have a team surrounding a patient and the doctor with a care concierge, with a pharmacist who keep in touch and keep the patient supported and engaged throughout their process. We have a dietitian, a health coach, all designed so that the patient feels empowered and supported, and then they can continue their care.
Yeah, and I also know that it's nice. You talked about dialing in, dialing up. There's a membership model that's basically how you want to consume it. So if there's a periodic period that you want to do, if it's longer term, continuous, there are different models that are available.
Yeah.
I think that's really smart. Because we've got 10 minutes, I think we ought to jump right into Q&A real quick, if that's all right.
You bet.
I'm looking at the questions here. One of them, both of them, it's a consensus that people are impressed with your with the content you share and want to know a little bit high level. What is some of your business and background? So, Tiffany, why don't you just weigh in on some of your experience about your insights that you've gathered in your career that help you arrive at this is sort of the solution. Share with the audience that. I'll have Alex do the same.
Well, I mean, just I think going back in time for a few decades ago, I started life very early as a patient. I was diagnosed with a chronic autoimmune condition when I was 1.5 years old called juvenile rheumatoid arthritis, and really shaped me as a patient, and ultimately was the impetus behind deciding to go to medical school and wanting to do a whole person holistic practice, because it's helped me so much as a patient in my outcomes, and I've done thankfully very well. I've been practicing for 20 years. I ran when I was with the health system I was with just prior to launching Vytal Health. I ran the largest integrative, ran the largest integrative medicine department in the United States, integrative medicine, again, being one of the holistic or whole person practices. And I grew that from me as the only fellowship trained integrative medicine physician to 22 physicians. And so I got very familiar with the community across the country during my training process and recruiting physicians, and thankfully I have a huge network of people from across the country who practice this way, and I've just seen it grow tremendously over the last couple of decades, which is very heartening. 30,000 practitioners, by the way, per year being trained in integrative and functional medicine, 30% year-over-year growth, which is amazing. And then I got involved in innovation towards the end of my career in the healthcare system, launched a couple of sort of startup companies within the healthcare system, and ultimately decided that I would have a better impact if I could leave and do it in a much more heart-focused, very specific way that meant a lot to Alex and I. And so Alex and I have known each other for a long time.
Way, right?
In a more intimate way.
Right,
exactly.
Right.
Yeah.
How about you, Alex? Your turn.
Yes. So my experience is really heavy on the business and technology side of healthcare. I've been doing this for 13 years. My passion lines with experience and relationships. I have many personal stories for how devastating it is when that relationship doesn't exist and the experience is just transactional and crappy. This is my third telehealth endeavor. Prior to this, I've built and operated the largest telepharmacy chain in the country, as well as worked for a leader in telepharmacy software and helped build it up and expand it. And eventually we exited it to Cardinal Health in 2016. Got an MBA education, initially thinking I wanted to focus on healthcare administration, but falling in love with entrepreneurship and being empowered with the ability to do and change the world and make it a better place.
And he's a pharmacist.
And I'm a pharmacist.
On top of that,
and he's a pharmacist. He's a PharmD. He's a doctorate level pharmacist.
That's awesome.
He's wasting no time.
And on the pharmacy side, I just like to say that just seeing the patients coming through who are just being managed, whose decline is being slowed down, is just very disheartening. Where these things can be solved, they can be prevented, they can be reversed if time went into it. And it's just been very disheartening on the pharmacy side of things.
So another question that's come up is impressive backgrounds, impressive ventures. You guys how long are you into Vytal Health? How many patients are you actively managing today? What is, somebody was asking.
So we're 2 years old.
Okay.
We have nearly 400 patients that we're managing now who are active with us.
Wow.
And we have 5 clinicians and growing.
Five clinicians and 400 patients. Okay.
Mm-hmm.
And with your current clinicians, what's the capacity of the 400 patients? With that group, you could grow to how many? And then the next question follows on is, so how do you best scale to support the demand? Because there's multiple people say, I can see where this is so needed. I need it, as somebody says. How do you best scale to support the demand? So answer the first part. How many can you scale to help support now? And then how can you scale?
Sure. So each physician can handle about 300 to 450 patients, depending on which membership plan they go into and how much attention they're requiring.
Got it.
So there's definitely room for additional patients. And scaling this, the first 2 years really went, a lot of hard work went into building the right infrastructure and foundation for that. Just like we talked about telemedicine, slowly building the foundation for telehealth of the future. We did the very same thing with our own technology. We built our own electronic medical record specifically designed for concierge style whole person health and holistic medicine care. So now we're ready to scale it. And we have about 30 physicians who are just waiting to get onto the platform and work with us.
Oh, wow.
Yeah, it's in demand on both sides.
I'm gonna move this next question and also open up the slide. It's because you have the audience of the family office, private wealth, alternative impact investor community. How can this group help? Because I'm gonna have you talk about it with this slide too, because I believe that you're at a place where you're going to, in order to bring on those 30 physicians and additional patients to support. You're in an investment raise now, but also looking for strategic partners and investors. But comment on how can this investor community help you?
Yeah, currently we are in the process of raising our second seed round to help us grow. With our first seed round, we've laid down the foundation, built all of our technology, and learned what our consumers are looking for and what our physicians are looking for. And now we're looking for partners and investors to help us grow our business to meet the demand on the patient side and the physician side that's out there and just waiting for somebody to help them. We're also looking for people who can make connections for us in the industry, can mentor us, connect us with experienced business leaders, as well as who believe and want to invest in women-led companies.
I would just add that the women-led startup companies, these are good investments. 2x return on revenues and 38% return on investment. So these are solid businesses. Women perform very well in business, and I think that that's also something to take into consideration.
Agreed. And here's what I wanted to also provide to the audience that's here, and we shared this slide earlier, but what we didn't share was the amount of investment capital that the industries and players are receiving in this sector. So it isn't one that hasn't been already vetted and people believe in it, and you can see where specific health problems, transactional relationships, different stages. So it is a healthy appetite for the investment community. I encourage people to take a look at this, and Vytal Health has a unique place in the ecosystem that it is not only delivering things specifically for the women's healthcare in all stages of life, but also deeply committed to that relationship development via the telehealth. So This is a great comparison, and people obviously can come back and take a look at this. So as part of our, we'll call it a wrap-up call to action, I would invite the investor communities who's receiving this and reviewing it. Here are Dr. Tiffany and Dr. Alex's contact information. Obviously, you can feel free to reach out to me, and I can help facilitate. But if there's any questions and or additional areas you'd like to explore and talk through, or more details about what does that present investment look like and materials, they'd be happy to share it. But hopefully everybody's enjoyed. Let's see, how did I do on time? I'm going to check my little stopwatch. I like to try to be, oh my goodness, 1 minute and 1 second. So we're doing
Impressive.
pretty well.
So there's
guys,
time for song and dance.
That's right. That's right. So again, everybody, thank you for being on here. You guys, appreciate you making the time.
Thanks,
Well done.
Danny.
Yeah, thanks, Danny.
We'll wrap up here and let everybody go and enjoy the rest of the day. Thank you, guys.
Appreciate it. Have a good one.
Mhm.
Bye.